Dr. Anee Moore is the Medical Director of the Weill Cornell Breast Center. She is a Professor of Clinical Medicine at the Weill Medical College, Cornell University, and attending physician at the New York Presbyterian Hospital. Although her primary interest is patient care, she is involved in teaching and research both at the national and local level. Her current clinical research involves survivorship issues as well as clinical trials for adjuvant and metastatic disease. Dr. Linda Vidot is a professor of medicine at Weill Cornell Medical College as well as attending physician at New York Presbyterian Hospital in New York City. She's currently the director of the breast cancer research program at Weill Cornell Medicine and co-leader of the breast cancer program within the Meyer Cancer Center. Until recently, she led the solid tumor service at Weill Cornell, stepping down in 2015 to focus more on breast cancer-related activities. Dr. Moore, thank you so much for joining us. It's all yours.
Thank you, Christine, and thank you to Cher, with whom we've worked for so very many years to help support our patients. And we're very, very grateful. In the United States, through 2017, we really have not until recently had statistics about the numbers of women with metastatic breast cancer. A new publication just in the last couple of months, which included one of Cher's supporters and workers, Musa Mayer, brought together the statistics that I think are going to be very helpful for us in the field. We all know how many women are living with a history of breast cancer in the United States is very large, 3.5 million women with a history of breast cancer. 155,000 women are living in the United States with a history of metastatic breast cancer. And 26,500 women are living 10 years or more with metastatic breast cancer. So there's a lot to do, a lot going on, and certainly the women are doing better than they did in the past. The article points out that with optimal care, women with metastatic breast cancer can and often do live for years with reasonable quality of life, albeit undergoing constant treatment to keep their disease under control. So what have we learned in the past few years, even before ASCO 2017? We've learned that every breast cancer is different. And a big study of breast cancer biology in 2012 pointed this out to us in a very important way. About 500 different breast cancers were analyzed by about 400 different brilliant scientists all over the world to look at the genes in the cancer, the nature of the DNA in each cancer, the RNA, the sequencing, the proteins in the cancer. And what they found was that every single cancer had a different fingerprint. Every cancer was different. Although they are all different, there are 4 general groups of breast cancer: hormone receptor positive, hormone receptor negative, and HER2 positive. The hormone receptor positive cancers can be divided, if we look at the gene sequence and the protein and so forth, into luminal A and luminal B. These are both estrogen receptor positive types of breast cancer. Another thing to remember for our patients with metastatic disease, that every breast cancer is different, and there are frequently differences between the primary cancer and the metastasis, so that we feel biopsy of the metastasis is very important, and we try to do it whenever possible. In this study by Amir et al., they showed that when there was a breast cancer recurrence, and the metastasis was tested, the receptors in the metastatic disease, 37.6% of the time were different from the primary cancer. And this is important when we're planning treatment. So the 37% of the time, the ER, PR, or HER2 in the metastasis is different from the original primary cancer. Should all breast cancers, primary or metastatic, be tested for what's called next-generation sequencing? This is trying to find all the genes in the cancer that can possibly be tested to see if there are genes that are mutated that could be used to guide us in treatment. This is called precision medicine, And a large company that does this is called Foundation One, and some of you may have heard of this, testing for gene mutations in the cancer. At present, this is not a routine analysis for breast cancer or for metastases from breast cancer. And there was no new information at ASCO that leads me to think that this should be done routinely. But keep asking your doctors about this. This is going to be important. So what about ASCO 2017? What's it like? Well, it's always held in Chicago because we have such a big group. There aren't many cities that can hold us. Almost 40,000 attendees from more than 150 countries come to the meeting. And what they have in mind is, what can I learn at this meeting to bring home to take care of that patient who's sitting waiting for me in the office? Papers with new findings about cancer were submitted and selected for presentation, and almost 12,000 were published in the proceedings. Here's my proceedings book that I just took a picture of. It's about the size of a small telephone book, and 12,000 abstracts are included, and many of these relate to breast cancer. And those that don't relate directly to breast cancer, we can learn a lot from lung cancer, colon cancer, kidney cancer. So it's a very important meeting for us. So what were the highlights? Well, I'm going to break out the highlights in terms of different types of breast cancer. For instance, the first group and the most common group of metastatic breast cancers are in women who are estrogen receptor and or progesterone receptor. These are called hormone receptor metastatic breast cancer. So what are active treatments for this disease, and what did we learn? For postmenopausal women, there's been a lot of attention on treating these women with aromatase inhibitors. And the common ones, we have three available now: anastrozole or letrozole, and they are very similar, and one that's a little different, and that's exemestane. I will use some of the brand names because some of you know these names better than the generic names. So that's Arimidex or Femara or Aromacin. A new area is working on cell cyclin inhibitors. These are additional drugs that stop cells from growing, and we're being added to aromatase inhibitors to make the aromatase inhibitors work better. And we're hearing a lot about palbociclib, which is Ibrance, ribociclib, which is Kisqali, and abemaciclib, which has not yet been brought out by the FDA. So what about letrozole and palbociclib, or Ibrance? In 2015, there was a trial called the Paloma. They have wonderful names, these trials. Paloma 1 trial, which showed that women with estrogen receptor positive metastatic breast cancer who took letrozole plus palbociclib as their first treatment after the diagnosis of metastatic disease had twice as long a response to the treatment than if they took the letrozole alone. And this was very exciting for us. So in 2017, we asked the question, the fact that they were doing better, their tumors shrank more often, and the shrinkage lasted longer. Did this mean that the women lived longer because their first treatment was letrozole plus palbociclib as compared to letrozole alone? So we heard the results of that longer follow-up from at ASCO. And this was an important paper for us, showing that the overall survival results from the randomized phase 2 study of palbociclib in combination with letrozole or letrozole alone were the first line treatment of hormone receptor positive, HER2 negative advanced breast cancer, metastatic disease. What was the difference in survival between the two treatment arms? And the answer was that although there did seem to be a better and longer response when adding Ibrance to the letrozole, the overall survival was not affected if a woman took letrozole alone or letrozole plus palbo at the time of diagnosis of metastatic breast cancer. Why is that? It's probably because we have so many other medicines to use if a woman has progression of the disease after the first line treatment. So if she has responded to letrozole or letrozole plus palbo, and then we see new disease after some time, we have many other treatments to offer so that the woman's survival is going to be the same no matter which of these medicines she started out with. But the benefit of the palbociclib is that she may have a longer time before she has to change medicines if she has the letrozole plus palbo as compared to the letrozole alone. So what does this mean for you if you have a first metastasis of estrogen receptor positive breast cancer? The aromatase inhibitor alone, in this study it was letrozole or Femara, may be the best treatment for you if this disease is what we call indolent, slow growing, and not fast growing. Letrozole alone is probably a very good treatment for that type of situation. If we need something that's going to work faster, letrozole plus palbociclib might be better for you if the disease is more active, if we see more areas of metastasis, and we need a faster response to treatment. Then we might suggest that we start the letrozole plus the Ibrance. So what else is new that we learned at ASCO for estrogen receptor positive metastatic breast cancer? As we mentioned before, we are very interested in these cell cyclin inhibitors, such as the palbociclib. And we have a new one, abemaciclib, given with a different hormone treatment, fulvestrant, known as Faslodex, the injectable medicine. And it's used in a different group of women. So it's a different study, different drug similar to palbo, different hormone treatment, Faslodex instead of letrozole, and a different group of women. These are women who've already had one hormone blocker treatment. So this was called the Monarch 2. And this study was abemaciclib, which is a new type of palbociclib, in combination with fulvestrant, which is Faslodex, in patients with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer, who already had one endocrine therapy, and now the disease has progressed. How did this study show results? What did we learn? Well, we had good news on this trial. The women with fulvestrant plus the new drug abemaciclib had less progression of their disease at a follow-up of 19 months compared to the women with fulvestrant alone. So here we have another additional drug that's giving us good results. We don't know yet. Will these women live longer by adding the abemaciclib to the fulvestrant? We don't know. These women are just only on their second round of treatment. There's many years ahead. Hopefully things will stay quiet, but if they need to make a change, we have a number of other drugs for them. So it may be that it won't affect how long they live. But we're excited to have another new drug showing very good activity in estrogen receptor positive metastatic breast cancer. So we have a new approach, which is the cell cyclin inhibition. This is a whole new class of drugs, palbociclib, abemaciclib. We have a third one, ribociclib, and we have more choices to treat this disease. And one thing it does mean for our patients, it's a longer time on hormone therapy before we switch to chemotherapy, which we often do as time goes on. How about switching away now from the hormone receptor positive breast cancers? What's new in metastatic HER2 positive breast cancer? Herceptin is a targeted drug, an antibody, targeted for the HER2 receptor. The HER2 receptor is something that activates cancer cells and increases their ability to grow. And we have an antibody which was discovered now almost 20 years ago. It's very active in quieting this HER2 receptor down. When combined with chemotherapy, Herceptin is very active against metastatic disease. It's not very active when it's just given by itself. So how about dual blockade of the HER2 receptor? Not just using Herceptin, but can we add something else to Herceptin against HER2 instead of just the one drug? And will we get even more better responses? This is called dual blockade, and it's a topic of great interest at ASCO. We know that there is one situation in which dual blockade does seem to be more effective than Herceptin alone. And this was a trial called Cleopatra, which was presented now 2 years ago. In that trial, it showed that Herceptin plus another HER2 blocking drug, pertuzumab, also called Perjeta, added to Taxotere, which is a form of chemotherapy, is more active than Herceptin and Taxotere alone for metastatic disease, which is HER2 positive. And this is now a new standard of care for metastatic breast cancer, which is Taxotere plus dual blockade of the HER2 receptor with both Herceptin and Perjeta. At ASCO, we're hearing about lapatinib, plus, which is a different route of blocking the HER2 receptor. Lapatinib, also called Tykerb, plus Herceptin plus chemotherapy. Lapatinib is available and may have use in metastases to the brain that might even be more active than Herceptin alone. And this is a topic of great interest. Another pill, which is a relative of lapatinib, is neratinib. Neratinib also blocks the HER2 receptor. It is not yet approved by the FDA for use, but it looks very active, and I think it will be available for use. That can be given plus Herceptin plus chemotherapy. And once again, appears to have activity in brain metastases from HER2 breast cancer. So a lot of interest, a lot of activity around trying to make that Herceptin response even better and stronger and longer lasting. One very interesting trial that we have all been waiting to see what would be the results is called the Marianne trial. And this was presented at ASCO. Women with metastatic HER2 positive breast cancer received one of the following treatments as first line. In other words, that means they came in with the first metastasis. They were given Herceptin plus Taxotere or Taxol, or TDM1, which is also Herceptin, but it's a Herceptin attached to a chemotherapy drug, maytansine. Maytansine is very toxic as chemotherapy, but if Herceptin brings it to the cell, it pushes it into the cell without sending the maytansine around to other organs and causing toxicity. So that's Kadcyla. And then they asked the question, well, what about we do dual blockade, not only Kadcyla, which includes Herceptin, but add the pertuzumab, the Perjeta. Would that be even better? Well, the women were put in one of those three groups in a randomized trial, and they found the results for all the treatments were equal, and in this case, the dual blockade was not superior. However, the trial does show us that TDM1 or Kadcyla alone is a very active agent for first-line treatment of metastatic breast cancer. It's very well tolerated, and we were in some of the original clinical trials testing Kadcyla, and one thing our patients really did like was that they did not lose their hair on TDM1 or Kadcyla. So how about triple-negative breast cancer? Well, we have learned triple-negative means that the estrogen receptor and progesterone receptors are negative, as is the HER2 negative. So we don't have the traditional targets of hormone blockade or of trastuzumab or Herceptin to target this kind of breast cancer. There's a tremendous amount of research in trying to find the targets in triple-negative breast cancer. And it's turning out that it's a very complex disease, not just one disease. It's probably many different types of breast cancers rolled into one, and our secret, of course, is to find which targets to treat. We have many active drugs in triple-negative breast cancer, drugs, chemotherapies that do work for this disease. And a big question that our patients are asking us almost every day is, how about immunotherapy? They are hearing so much about immunotherapy and the excitement that we have had in the field about lung cancer and melanoma. These are diseases that over the years we've had almost nothing to make metastatic lung cancer or metastatic melanoma go away. So when we found out that immunotherapy does help in those diseases, we thought, well, that's great. We can use it in breast cancer. Up until the present, we have seen some activity for immunotherapy in breast cancer, but not as active as we had thought it might be. So the immunotherapy that has received the most attention is called, the trade name is Keytruda, or pembrolizumab, we call it Pembro, is active in some cancers, as we talked about, melanoma or lung cancer. And the paper that received a lot of attention at ASCO was a phase 2 study, that's an early study, of pembrolizumab alone, that's called monotherapy, not combined with anything, in women with previously treated metastatic triple-negative breast cancer. And we found that immunotherapy does have promise in metastatic breast cancer. The study showed that the pembrolizumab monotherapy showed some anti-tumor activity in a subset of patients who had had triple-negative breast cancer and had multiple previous treatments. We thought we might have a marker for whom would Pembro be active. Some tumors carry a receptor called PDL1, and we thought maybe Pembro targets that receptor. Maybe this is the group of patients that's going to respond to immunotherapy. But it appeared in the women who did respond to immunotherapy, it didn't matter if they had that PDL1 expression or not. So the activity may be greater in patients with less heavily pretreated disease, so maybe we should be using it earlier in the course of the treatment. The treatment is well tolerated with pembrolizumab, although again, as a new drug, we are watching our patients very carefully who are receiving pembrolizumab on clinical trials. And there are randomized trials now going on studying pembrolizumab along with other treatments for triple-negative breast cancer. So how do we select our questions in immunotherapy are, how do we select the right patients? And how do we select the right tumor? And how do we select the right patient with the right tumor? This is a hard nut to crack, but there's a lot of interest, a lot of work on this very question. A major paper that was selected for what we call the plenary session. The plenary session at ASCO is a session where everyone together comes to hear the most important papers of the year, the most important research. The room is enormous. It's bigger than an airplane hangar. And it's just packed with oncologists from all over the world sitting there. We can't wait to hear the results of these papers. 4, 5, or 6 papers are selected. This year, they're selected. There's a kidney cancer paper, a lung cancer paper, a melanoma paper, and we had an important breast cancer paper. This was a paper describing a new way to treat metastatic breast cancer in women who carry the genetic mutation of the BRCA gene. And in this trial, a new drug was given, olaparib. Olaparib is a PARP inhibitor. You probably have heard that term, PARP inhibitor. It's very specifically interferes interferes with breast cancer division and breast cancer growth in cells that carry a mutation for the BRCA gene, either BRCA1 or BRCA2. This was called the Olympiad study design. And if you just follow along a little bit, if you look at the white box, this was designed for women with HER2 negative metastatic breast cancer. It either could be estrogen receptor positive or triple negative breast cancer. The patients had to have a gene mutation for the BRCA gene. They'd had prior treatment, but in general, these women are healthy and well and ready for a clinical trial. Because these are BRCA gene mutation carriers, the average age of the woman was in the 40s, because these patients tend to get breast cancer earlier. And half the patients received the new drug, 2/3 of the patients received the new drug, olaparib, which is given by mouth and well tolerated. The other third received chemotherapy, and the physician could choose either capecitabine, which is Xeloda, eribulin, which is called Halaven, or vinorelbine, which is called Navelbine. And neither the women nor the patient, or the patient's doctors, could choose whether to get into the green box and get olaparib, or whether to be in the red box and get chemotherapy. So the women were given these treatments, and then they were studied to see how if they responded and how long did they respond. Here was, I thought, a very exciting slide. In the first, looking to your left, you see the overall response. How many patients responded to this brand new approach to metastatic breast cancer? 60%. And these are women who've had multiple other treatments. And we found this extremely exciting. There were 30% of the women did respond to the chemotherapies, so we were happy that they responded, but very happy with this new approach. Not all of them had a complete response, not all the disease disappeared, but indeed 9% of these women with the new drug, we couldn't find the disease after the trial of the new drug. So we think that this is, again, a very exciting new approach. The responses didn't last forever, but for some of the women, they responded for a long time. So for BRCA mutation carriers with metastatic breast cancer, whether it's estrogen receptor positive or triple negative, the conclusions of this trial was that the olaparib tablet monotherapy provided a significant and clinically meaningful, and that's really important, that it meant a lot to the patient to get better from the metastatic breast cancer. It was generally well tolerated. Less than 5% of the women stopped the medicine for side effects, and that's pretty good very good in our field. And it's the first phase 3 study in metastatic breast cancer patients demonstrating the benefit for a PARP inhibitor over an active comparator. In other words, the 3 medicines that were compared are active in the treatment of breast cancer. So this was received with enormous excitement and enthusiasm, not only for the results of the trial, but because it's really opening up a whole other road for us to take. So what do we think were the highlights of ASCO 2017? The highlights were really that it opened new pathways. So for patients with a BRCA mutation, PARP inhibitor in BRCA mutation carriers is aimed at a specific problem caused by the gene mutation. The scientists who have worked so hard in the lab to define that mutation their work has really come to great fruition when we can actually target that mutation. And there's a lot of research going on with different PARP inhibitors. We hope better PARP inhibitors that will be able to be tailored not just to patients with BRCA mutations, but patients with other types of cancer, particularly the triple-negative breast cancer patients. What else did we learn about patients with estrogen receptor-positive breast cancer? We learned about cell cyclin inhibition, aimed at slowing down cell growth and making cells more sensitive to anti-estrogen therapies. And these were the newest drug, abemaciclib, which we think will be brought out by the FDA. I think it will be available to our doctors, aimed based on some of these results we saw. Ribociclib, which has become available, and palbociclib, or Ibrance, which has been available now for about 2 years, and we're all learning the value of that drug. We learned about patients with HER2-positive breast cancer, expanding on the great success of Herceptin by adding more anti-HER2 drugs in combination with Herceptin. Seems to be the best way to give them. And there's more and more research going on in that field. So we were excited about the HER2-positive breast. So for patients with, what else did we learn in ASCO 2017? For patients with triple-negative breast cancer, we are excited about the concept of breaking the code. We learned about immunotherapy. We are seeing some activity for immunotherapy in triple-negative breast cancer. We feel this is just the beginning of this approach to triple-negative breast cancer. I have with me Dr. Linda Vedot. Dr. Vedot has a special interest in triple-negative breast cancer and has led some of the trials both at our institution and nationally, as well as internationally in this field. We have multiple clinical trials at Weill Cornell Medicine, and I'm asking her to comment on the trials and how they would pertain to what we see for the future and what you might learn from her review of our clinical trials. Dr. Vedot.
Good afternoon, everybody, and thanks for joining in this webinar. So at Weill Cornell, we are very interested in having something available for everyone. And the way we've built our research program has really been to integrate everything we're doing on the clinical as well as the scientific end. And a lot of the things we do, we're really trying to understand the whys of breast cancer. So, you know, why do people get numbness, tingling, fingers, toes, or what we call peripheral neuropathy? Why do tumors spread after being dormant in a cult for years and years? But while we do a lot of our own research, we also participate in research that's being conducted nationwide as well as worldwide. And so just to give you some of the insight into some of our adjuvant trials, well, as you can see from the slide, we've really separated into what we call the molecular subtypes, because that's how we think about breast cancer these days. So in the adjuvant setting, of course, is when someone has had their primary tumor removed, usually by surgery, and now they need some additional therapy to reduce risk of recurrence. For hormone receptor positive breast cancer, we have one clinical trial, which is, you'll see it's S1207, which is run by the Southwest Oncology Group, and we participate in it, looking to basically improve endocrine therapy by adding in everolimus. Many of our patients who have breast cancer are young, and because they're young, they maybe haven't had their children yet, if that's what they would like to do. And so there's a large international effort going on with the positive trial, as you can see, looking at the safety of interrupting hormonal therapy in patients who are hormone receptor positive, have had a hormone receptor positive breast cancer to have a pregnancy. So in terms of for the triple negatives, we have a number of other trials looking to improve outcome for triple negative breast cancer in the adjuvant or the neoadjuvant setting. And when we look at our supportive care correlative and biobank studies towards the end of your screen there, we have a triple negative breast cancer program, and it's really very much focused on our metastatics because the idea is we're really trying to integrate research and treatment under one roof. We employ precision medicine. We pretty much sequence every tumor that comes to us in order to really understand how it grows, and then participate in clinical trials, things we call basket trials or the NCI match trial, in order to really try to move away from a one-size-fits-all and really target the therapy as best as we can. We are also very interested in things such as reducing fear of recurrence, stress reduction, self-healing. We have a pilot study of guided meditation. And then we have other studies going on looking at, you'll see at the bottom of the screen the satisfaction survey, trying to find out and get input about these new survivorship care plans, which everyone is moving towards, to basically make treatment as transparent as possible. In terms of our metastatic trials, we have, as you can see, many trials here. And again, looking at the ER/PR positive trials, most of our studies are geared towards making hormonal therapy work better, and we have participated in the atinostat study. When PI3 kinase is basically the target of our Millennium study. When you think about the second most common mutation in breast cancer, it's PI3 kinase. So this is a brand new PI3 kinase study that we are testing in combination with hormonal therapy. And then in the middle of the hormone receptor positive group, we have our IMMU study. So IMMU is a drug which is like really a great drug for triple negative breast cancer. It's what we call an antibody drug conjugate, and it's actually been designated to have breakthrough status through the FDA. And because it's really such a blockbuster in triple negative breast cancer, we're evaluating it in patients who have ER positive tumor, because the target, which is something called TROP2, is also present in ER positive breast cancer. So in the HER2 positive space, we're very lucky that most patients who have been treated with HER2 positive therapy in the adjuvant setting, most patients don't relapse anymore, but if they do, we have something for them. And one of them is combining Herceptin and ruxolitinib, which is very promising. It's a trial we do with Columbia. Neratinib is a brand new targeted agent. It's a super duper lapatinib. And we're running a trial with that. And then we have a new and improved version, we believe, of Herceptin with the macrogenic study, and that we're running that trial. For triple negative, we have a number of older and newer drugs. The Celldex drug is an antibody drug conjugate we've been working with for many, many years, and now it's almost at the FDA approval stage, and this is a registrational trial. Patients need to have this thing called the GPNMB, and basically what GPNMB is, it sort of helps cells to move around. So what we're doing is that we're sort of cutting off the legs of the tumor, so to speak, and then delivering a chemotherapy punch to it. We have two other drugs which represent new targets. We have a Wnt inhibitor. Wnt is real, and that's our Rexan drug. With our Wnt inhibitor, it's a pretty exciting drug because tumors need something called Wnt in order to move around. And so with this pill, it's felt that basically, again, cuts the legs off of the tumor. And another study we have with Oncotherapy Sciences is with a MELK inhibitor. And there's a lot of data that suggests that it would be very active in triple negative breast cancer. That's a brand new study that just opened. We think about breast cancer in lots of different ways, and we think about patients who have BRCA mutations, which of course are inherited mutations, in their own little category. And as you may have heard, PARP inhibitors are very exciting, but we have sort of the second generation of drugs targeting BRCA1 and BRCA2 is the family of drugs that's in our PharmaMar trial. This drug is lurbectedin, and it's a very active drug in BRCA mutation carriers. I've already sort of mentioned some of our other targeted agents, which basically target the mutations. That's why we try to sequence everybody. That is with the Genentech pathway study. So basically, we have access to their drugs based on target and not necessarily on tumor type. We also have the NCI match study, which there's a list of maybe about 30 drugs that we have which targets the tumor pathway, as opposed to thinking about treating breast cancer or colorectal cancer. We're just thinking about, okay, it's a PI3 kinase or a BRCA mutated cancer or an EGFR mutated cancer. We also have I always call it a poor man's immunotherapy, our Lilly study, which is the LY2157229 with radiation therapy in breast cancer. We have an incredibly innovative radiation oncologist that works with us, Dr. Sylvia Fermenti. I'm sure many of you will be familiar with her. And she's done a lot of work on understanding the role of radiation in immunotherapy of breast cancer. So in that study, patients can get a lesion, just a little bit of radiation to a lesion. They take this TGF-beta inhibitor, and basically what it does is it activates the immune system to fight cancer in other sites that are not being radiated. And we've seen some good responses with that. Our last study on the targeted column there is our TLR7 study, and the idea behind that is that we activate the immune system, again, by giving a little bit of radiation, and we use a particular cream on a chest wall metastasis, and we've seen some good responses with that too. So as you can see, there's a lot of options, and this is really just a little snapshot of all the different things that are going on, not only at Weill Cornell, but really nationwide. I mean, there are a lot of really very promising drugs out there, which we're really looking forward to hopefully making them available for patients soon.
Thank you very much, Dr. Vedat, for this whirlwind tour of what we're going to hear in ASCO 2018 and 2019. We certainly appreciate Cher's giving us the opportunity to discuss ASCO 2017, Advances in Metastatic Breast Cancer. Thank you.
Thank you both. We have several questions from the audience, so we'll begin. First question is, many oncologists are stating that women are living longer with metastatic breast cancer, but as far as we know, the median life expectancy is still around 3 years. Can you speak to that a little bit, or can you clarify, or does this mean that some women with certain types of metastatic disease are living longer?
So basically, I think what it depends upon is what's the molecular subtype of breast cancer. Some breast cancers do very, very well. For example, the luminals, the ER positive and the HER2 positives tend to live for a very long time. And really where the challenge is with the triple negative breast cancer, because you don't have as many targets as we normally do. So I think that's sort of bringing down the average, if you want to even think about it that way. Although I would say with the triple negatives, I would say that they're living longer, because what I find is that most triple negatives, as soon as their tumors come back, if they come back, they're already looking for new therapies, as opposed to just going with the same old, same old. So unequivocally, we all have patients who have metastatic breast cancer who live, for more than 10 years. So I think we're just going to keep on seeing that as we have more active drugs available.
Great. Next question. So obviously in your institution, sequencing is done on all tumors, it seems. Why is this not always the case in the metastatic setting?
Well, I think, and I remember when I first started sequencing tumors, the thing is most oncologists are data-driven. And, they would like to know if there's a particular molecular alteration that if they give drug A, B, or C, that they have a reasonable expectation of benefit. And I would say the science has moved quicker than the clinical information to support it. So I actually, I have colleagues who used to sort of make fun of me when I used to why are you sending off that test? But I think as we've gotten more comfortable with it, I find that when you sequence tumors, I would say not infrequently you are surprised about what you find, and it points you. I find it as a great screening tool for trials. So I find it very, very useful. Now the thing is that those tests are really expensive, so it's not like you can keep on doing them all the time. I know that there's going to be some new technology coming out soon that's reasonably priced, looking at circulating tumor DNA, that what's in the bloodstream, and I think that's going to really be very helpful. So, like for example, one of the things that's sort of emerging there is that if someone has what's called an ESR1 mutation, that basically predicts impending resistance to aromatase inhibitors. So if you have a tumor that has it in its sort of DNA from the very outset, then maybe you may not give them an aromatase inhibitor. So I think the clinical stuff has to sort of catch up with the science.
I think, this is Dr. Moore, I think to go on the other side of the picture, the current guidelines for management of breast cancer do not include the recommendation for sequencing for every tumor. So I think for our patients who haven't had the gene sequencing of their tumor done, they shouldn't feel that this was missed. We're very excited by the data coming in, and we do hope in the next few years that we will be able to use it for more treatment decisions. Certainly, however, for the clinical trial work that Dr. Vedat and the group here at Cornell is doing, we have certainly found it very helpful to us, very of great interest for future research, and at times I do think so helpful for the patients.
Mm-hmm.
So there are a couple of questions about mixed subtypes. And can you speak a little bit about how you might treat a patient who has some lesions with, some metastatic lesions with ER positive and some with triple negative, for example?
As we pointed out in the early slide, the metastasis is different from the primary cancer in 37% of women. And sometimes it's a big difference, like a tumor becoming HER2 positive, or a prior estrogen receptor positive cancer becoming estrogen receptor negative. So we tend to treat aimed at the biology of the metastasis when we are treating patients with metastatic disease.
What I would say that, and I fully agree, is that you have to keep an open mind. So if things aren't going exactly as you think, then maybe you should think about, well, if this was a HER2 positive breast cancer in the adjuvant setting, it's HER2 negative in the metastatic setting, and you sort of commit yourself to thinking about them as a HER2 negative in the metastatic setting. If things aren't going as you think, then add in some HER2-directed therapy and see what happens.
And in patients where there are different subtypes currently, right? So on some organs there's ER positive, and other organs there's triple negative.
Yeah, I mean, you're sort of stuck, with probably having some chemo in there. That's what that means. From a clinical research point of view, I will use whatever biopsy I need to make them a candidate for whatever clinical trial I want them to go on. So, for example, I mentioned how in the, we have the IMMU study for ER/PR positives. So, I have some patients who had, were maybe treated as a triple negative, but they had one biopsy that had a little bit of estrogen on it. So I felt like really good saying, listen, you need to go into this trial because this is a fabulous drug for triple negative, which is how we've sort of been thinking about you. But you have this one biopsy that's a little bit of ER positivity, and that makes you a candidate for the trial. So I feel like I sort of use these things to maybe push patients in the direction I think they need to go.
Okay, next question. Can other CDK inhibitors be used when Ibrance, for example, fails?
Yeah, we don't know yet. Those trials are ongoing.
And a couple of questions about lapatinib and neratinib. Can you speak a little bit about the side effects?
Yeah, I mean, so lapatinib's been around for a really long time. It's a pill. It's targeting HER2/neu. It has mostly diarrhea and skin toxicity as its major side effect. Neratinib basically is a more potent TKI, which is the family drugs lapatinib's from. It probably works at least twice as well. And sort of, I always say its wart is that it has some diarrhea. And the thing is that when they first started using the drug, people up to 40% of people had really, really bad diarrhea. With sort of prophylaxing people with antidiarrheals, it's down to about 15%. So. But it appears, that it's a very active drug. It's currently under review by the FDA to be given after 1 year of Herceptin in the adjuvant setting, and I really hope it gets its approval.
Can you talk a little bit about whether or not you think PARP inhibitors can benefit the non-BRCA population?
Well, I don't think that PARP inhibitors have been exactly a home run for non-BRCA, germline BRCA mutation carriers. But with that being said, there are other there are other germline mutations which are associated with BRCA or with the same sort of homologous repair deficiency that makes us think that it would work. So, for example, you know, if someone has a PALB-B2 mutation or a BRIP1 mutation, those are very similar to BRCA mutations. You know, I've had patients on PARP inhibitor trials in other places where they actually responded. So it's not germline BRCA. And then, of course, what we don't know is tumors which have a somatic mutation in BRCA, you know, is there a role for a PARP inhibitor? There might be. So I think we need to keep our minds open.
And someone is asking, how often do you recommend sequencing tumors?
Well, I think we have two approaches on that. I think in a center where clinical research is central to the evaluation of the patient, sequencing the tumor would be done more often in order to see if there's eligibility for a clinical trial. In a community practice, sequencing of the tumor might be done less frequently because we have many good drugs for which sequencing really makes no difference to the efficacy of the drug. So I don't think it has to be done on every new patient with breast cancer or every new patient with metastatic breast cancer, but I think we will be seeing it more and more as we learn how to interpret the results. Dr. Badat.
I don't think that there's you know, a right answer or a wrong answer, you know, in terms of, you know, how often do you sequence somebody? I think you have to sort of look at the clinical scenario, and I think you feel a little bit more pressured to sequence when things aren't going exactly as you would predict. So I don't know, maybe that's about 20 to 25% of the time.
Mm-hmm. So someone is asking, what is the process you go through to help determine which clinical trial is best for a metastatic breast cancer patient?
Well, I think you have to talk to your doctor, and then I think it's always good to get other opinions. So, like, for example, it's not unusual here, you know, in New York, I mean, I feel like we're very lucky because, you know, there are a lot of really good institutions around us. And I would say that all the different sort of point people there who do metastatic breast cancer, we all have different trials. And so we call up and we'll say, do you got anything for a triple negative breast cancer patient who's been through 3 lines of therapy? And they'll say yes or no. And so you'll send them to them and, you know, they'll evaluate them. So, you know, it's I don't want to say it takes a village, but it sort of takes a village, I feel, to take care of a metastatic breast cancer patient. Because you may not have everything, you know, underneath your roof for them, but I think it's important for you to be able to send them to places where you think that there might be something which is very valuable for them.
And I think it is important for our patients to speak to their primary oncologist. And if the patients are interested in knowing what's available on clinical trials, asking their primary oncologist to call one of the clinical investigators at some of the larger hospitals. The clinical investigators are very open to speaking to the oncologist. We're all in the same boat. All we want to do is get these patients better. So I think they shouldn't be shy about asking for that communication.
So there are a couple of questions about men participating in clinical trials. So in particular, did men participate in the clinical trials at Weill Cornell, and were men included in the Olympiad study?
You know, I don't know if men were included in the Olympiad study. I don't think so. It depends on how the clinical trial is written. I would say that about 50% of them will say that it's okay to enroll men with breast cancer. I mean, I guess it's an opportunity for men to sort of get out there and say, well, hey, we want to be included in the same, you know, same proportion in all these different trials.
And another question about CDK inhibitors. Are any of them showing any CNS activity?
Yes, I think the abemaciclib does, actually. I think abemaciclib might have some CNS activity. I'm not positive, but I'm pretty sure.
Question about liquid biopsy versus tissue biopsy. What are your thoughts?
So the tissue biopsy is actually better. We are in the process of completing a paper specifically on that, you know, in terms of the number of mutations that we see. So I think if you have an option to do a tissue biopsy, I think it's better. But if there's for whatever reason you can't do it, then a liquid biopsy is sort of second choice.
Can you explain what a liquid biopsy is, Dr. Badat?
So a liquid biopsy, so basically liquid biopsy is circulating tumor DNA. So you have a tumor, it sort of sheds bits and pieces of itself into the circulation that is then measured with circulating tumor DNA.
Thank you.
And just looking through to see if I missed any questions.
If you didn't, Christine, I just want to say that our sense of what's going on in metastatic breast cancer, we think the future is bright. I think our clinical trials are thriving. We want everyone to support research. And I want to thank my colleagues here at the Breast Center, which is Dr. Badat, Dr. Sigler, and Dr. Andriapoulou, and to Dr. Maura Dickler, my colleague, for sharing her recent presentation on highlights from ASCO with our group, because she knew that we were presenting this to our share audience.
Thank you, and I think we're all happy to hear that your clinical trials are thriving. We're not hearing that so much from many of the pharmaceutical companies and other institutions that we work with. And you know, as we know, there's no research without participation in clinical trials. And just so everyone knows, SHARE has on our website 2 clinical trial search engines that can connect you with proper clinical trials for your specific type of disease. And one is Emerging Meds, and one is a metastatic trial search. That's part of breastcancertrials.org. And one of the services, at least, offers a navigation component to it, which we're told by our constituents has been really incredibly helpful. So it's a resource on clinical trials finding. And in fact, we're having a webinar, I believe, on Monday, finding clinical trials for metastatic disease. So thank you both for a really informative webinar. We really appreciate your time. Thank you all for participating.
Good. Thank you so much.
Thank you.
Bye-bye now.